Hi everyone, this is a PRL on platelet disorders. I'm Natalie Hillerson, a member of the class of 2022, and this PRL was made for the Medical Education Teaching Elective in spring 2020 and revised in spring 2022. So to begin, here is an overview of platelet disorders and the features common to each one. Generally, a platelet disorder is a defect in platelet plug formation, which is the first step in hemostasis after blood vessel injury. So as you might expect, if there's an issue with hemostasis, then common presenting symptoms of someone with a platelet disorder are mucous membrane bleeding, such as gum bleeding or epistaxis, petechia or purpura, and easy bruising. And as a quick reminder, petechia are small purple-brown spots on the skin that represents bleeding under the skin, and purpura are larger than petechia but are also indicative of bleeding under the skin. So lab findings will show an increased bleeding time for all platelet disorders. Platelet count is sometimes decreased, but it depends on what is causing the problem. And PT and PTT will be normal as the coagulation cascade is unaffected by platelet disorders. And there are 5 major platelet disorders that this PRL will cover, and they are listed here. So platelet disorders can be classified into either acquired or inherited diseases. Acquired causes of platelet dysfunction include Idiopathic Thrombocytopenic Purpura, or ITP, Heparin-Induced Thrombocytopenia, or HIT, and Thrombotic Thrombocytopenic Purpura, or TTP. And TTP, however, can also have a genetic cause and be inherited, so I've lumped it visually with the inherited platelet disorders by giving it this ombre effect. Other inherited platelet disorders are Bernard-Soulier Syndrome and Glanzmann Thrombasthenia. We'll start with a deeper look into the acquired disorders and then make our way to the inherited disorders, and I'll keep the color coding seen on this flowchart as we progress through each disease. We'll start with Idiopathic Thrombocytopenic Purpura, or ITP, also called immune thrombocytopenia, and this is the most common cause of thrombocytopenia. It's caused by autoantibodies to the GP2B3A glycoprotein on the platelet surface, and these platelets are now tagged with an antibody, and as they travel through the blood, the spleen and its resident macrophages recognize this antibody tag and destroy the platelets. ITP is therefore a destructive thrombocytopenia. Platelet count is low because the platelets are physically being destroyed. Clinically, ITP is most common in young adult women younger than 40 or children younger than 10. ITP can be idiopathic, or it may be caused by an autoimmune disorder, recent viral illness, malignancy, particularly a lymphoid malignancy, or a drug reaction. Patients will present with petechia, easy bruising, epistaxis, and mucocutaneous bleeding. There is no definitive test to diagnose ITP, so other causes must be ruled out. Labs will show increased bleeding time and a decreased platelet count. Peripheral blood smear will show large, young platelets, and bone marrow biopsy will show increased megakaryocytes. If patients are not actively bleeding, they may be safely observed while the underlying cause is being identified and treated. If patients have minor to severe bleeding, steroids and IVIG can be given. And with critical bleeding, patients are given platelet transfusions. Heparin-induced thrombocytopenia, or HIT, is the most common drug-induced thrombocytopenia. When platelets are activated, they release platelet factor 4, or PF4. And PF4 can bind heparin, and this PF4 heparin complex can be targeted by IgG antibodies. And this antibody PF4 heparin complex then activates platelets, leading to thrombosis and thrombocytopenia. So in this case, the thrombocytopenia is seen because of widespread platelet consumption rather than destruction, as is the case in ITP. Clinically, HIT will present around 5 to 14 days after starting heparin, and patients will present with excessive clotting and thrombocytopenia. The diagnosis is suspected based on clinical presentation, especially in a patient with a recent heparin initiation, but it also can be confirmed with an ELISA test for the presence of IgG antibodies. Labs will show increased bleeding time and decreased platelet count. Treatment for HIT is to discontinue heparin and start an alternative anticoagulant. And patients with a history of HIT will need to avoid heparin for the entirety of their lives. Thrombotic thrombocytopenic purpura, or TTP, as the ombre background indicates, can be both an acquired or inherited platelet disorder. And the issue in TTP is with an enzyme called ADAMTS13, either acquired antibodies that inactivate the protein or an inherited deficiency of this protein. The inherited form of TTP is very rare, so I'll be focusing on the acquired pathophysiology. ADAMTS13 is a metalloprotease that degrades von Willebrand factor multimers, attenuating platelet activation and aggregation. But if antibodies render ADAMTS13 non-functional, von Willebrand factor multimers go unchecked and continue to activate platelets, leading to another consumptive thrombocytopenia. So the platelets are low because they're all activated and aggregated in fibrin mesh. They're being consumed rather than being destroyed. The classic symptoms of TTP are a pentad of fever, microangiopathic hemolytic anemia, thrombocytopenia, renal failure, and neurologic symptoms. Diagnosis is based on clinical presentation, but ADAMTS13 activity testing can be done, though treatment should not wait on the results of this test. Lab findings include increased bleeding time, decreased platelet count, and increased lactate dehydrogenase, which is a marker of the intravascular hemolysis that occurs in TTP. Peripheral blood smear will show schistocytes, which represents red blood cells that have been physically cut or sheared by the increased amount of fibrin mesh created in TTP. Treatment is plasma exchange therapy, which removes anti-ADAMTS13 antibodies and adds back in functional ADAMTS13 enzyme. Steroids can also be used. And of note, TTP is very similar to hemolytic uremic syndrome in children, which is most commonly caused by the Shiga-like toxin of an enterohemorrhagic E. coli infection. HUS less often presents with fever or altered mental status seen in TTP, and instead presents with diarrhea, but the treatment is similar for HUS as well. Now let's move on to the inherited causes of platelet dysfunction. First is Bernard-Soulier Syndrome, which is an autosomal recessive disorder leading to a defect in the GP1B glycoprotein. This glycoprotein binds von Willebrand factor and is an essential step in platelet adhesion to the site of injury. Without a functional GP1B, platelets cannot adhere to von Willebrand factor and platelet plug formation does not occur. So symptoms, as expected, include severe bleeding tendencies, easy bruising, etc. And diagnosis can be done through a ristocetin test. Ristocetin activates von Willebrand factor and can induce platelet adhesion, assuming everything else is functional in that pathway. But without GP1B, there will be no platelet adhesion, even in the presence of ristocetin, so the test will be abnormal. Lab findings include a prolonged bleeding time, but platelet count may be normal or it may be decreased. Additionally, a peripheral blood smear will show large platelets. The platelets are large presumably because GP1B also helps with membrane stability and structure, so without this functional protein, the platelet membrane isn't as organized and the platelets become enlarged. Treatment for Bernard-Soulier is a platelet transfusion, just getting healthy platelets back into circulation. The last platelet disorder we'll discuss is Glanzmann Thrombasthenia, also an autosomal recessive inherited disorder. But here, the issue is with GP2B3A, which normally is essential in platelet aggregation. And GP2B3A binds fibrinogen, which is the bridge between two platelets. Without GP2B3A, platelets cannot aggregate or adhere to one another, and platelet plug formation is inhibited. As expected, the clinical presentation will be similar to other platelet disorders: purpura, severe bleeding, easy bruising, so on. Lab findings will show an increased bleeding time, but a normal platelet count. And further, a peripheral blood smear will show no platelet clumping. And like Bernard-Soulier, treatment for Glanzmann Thrombasthenia is platelet transfusions. So to cap off this PRL, I've included 3 practice questions for you to go through at your own pace. I'll read the question and then encourage you to pause and think about your answer, and then I'll go through an explanation with some additional questions that you can mull over on your own. So first, question 1. A 28-year-old woman with no significant medical history is brought to the emergency room for a 1-day history of lethargy and progressive confusion. She also reports gum bleeding and decreased urine output over the past 2 days. Her temperature is 38.7, blood pressure 118/76, and pulse is 105. On exam, she has a petechial rash and pitting edema in the lower extremities bilaterally. A deficiency or defect in which of the following is responsible for her current condition? A. GP2B3A, B. Platelet factor 4, C. ADAMTS13, D. GP1B, or E. von Willebrand factor. And pause now if you need more time to think. So the answer to question 1 is C, ADAM-TS13. This patient has symptoms of fever, altered mental status, noted by the worsening confusion and lethargy, oliguria, so decreased urine output, and gum bleeding, which makes you think of an underlying thrombocytopenia. And these are 4 of the 5 classic symptoms of TTP. So TTP is associated with a deficiency of or antibodies to ADAM-TS13, which normally degrades von Willebrand factor multimers and attenuates platelet activation. And without ADAM-TS13, von Willebrand factor is unchecked and just continually activates platelets. So some more questions to test yourself. What would you expect to see on a peripheral blood smear in this patient and why? And what is the 5th symptom in the pentat of TTP, and what labs would illustrate that finding? So next, question 2. A 5-year-old male is evaluated for frequent epistaxis and easy bruising. Physical examination shows diffuse petechia on the patient's distal extremities. Peripheral blood smear shows an absence of platelet clumping. Which of the following is the most likely diagnosis? A, Glanzmann Thrombasthenia, B, hemolytic uremic syndrome, C, Bernard-Soulier Syndrome, or D, Idiopathic Thrombocytopenic Purpura. Pause if you need to. So the answer for question 2 is A, Glanzmann Thrombasthenia. And when the vignette features a child, I always pay special attention to a potential inherited cause that's causing this child to present so early in their life. And easy bleeding and bruising point to a platelet disorder, and then the absence of clumping on peripheral blood smear is key and indicates that this child has Glanzmann Thrombasthenia. So some more questions for you. What protein is defective in these patients, and how does that relate to the lack of clumping seen on the peripheral blood smear? And in what other platelet disorder is this protein implicated? And in contrast, what would a smear show if this child had Bernard-Soulier syndrome? Lastly, question 3. A 36-year-old woman has had nosebleeds, easy bruising, and increased menstrual bleeding for the past 4 months. On physical examination, her temperature is 37, pulse is 88, and blood pressure is 90/60. Physical exam reveals scattered petechia over the distal extremities bilaterally. Laboratory studies show a hemoglobin of 12.3, hematocrit of 37, platelet count of 22,500, and a white blood cell count of 9,780. Peripheral blood smear is shown below. And what is the most likely diagnosis? A, thrombotic thrombocytopenic purpura, B, disseminated intravascular coagulation, C, Glanzmann thrombasthenia, D, idiopathic thrombocytopenic purpura, or E, Bernard-Soulier syndrome. Pause if you need to. The answer for question 3 is D, idiopathic thrombocytopenic purpura. So again, easy bleeding, bruising, and increased menstrual bleeding are all classic symptoms of a platelet disorder. And her physical exam findings of scattered petechia support that as well. And her labs show that her platelet count is very low, which favors a more acquired platelet disorder rather than an inherited one. She's also a little bit old to be presenting with an inherited platelet disorder. And the peripheral blood smear shows a large young platelet in the center of the field. So taken together, this presentation is consistent with ITP. And to further test yourself, what other features of this patient's history, if present, might support a diagnosis of ITP? And if instead this patient had started an anticoagulation drug last week and was now presenting with easy bleeding, what diagnosis would you be thinking about, and how would you confirm that? I've included overview tables here at the end. Making tables always helped me sort out different diseases, so I've included the acquired causes of thrombocytopenia table here for you to screenshot or look back on, and the inherited causes of thrombocytopenia on this slide. And if you have any questions about this content, please don't hesitate to reach out to your TAs or your professors. Thank you.